Hello, everyone. This is welcome to the latest in our Network Friday Forum. My name is Steve Piasecki. I'm the Upstate Coordinator with the network. For those of you unfamiliar with the network, we are a statewide membership and advocacy organization promoting supportive housing. Permanent housing with supportive services is the answer to homelessness for many vulnerable New Yorkers with life challenges. A special thank you to our sponsors and a huge shout out to our team, especially Cynthia Stewart, Joelle Ballum-Schwan, and Emily Levine, who've made all this technical stuff possible. Really appreciate that. I want to remind everybody this is part of a series. Next week, we are doing housing and homelessness, how to move forward post-pandemic, same time next week. We are doing this in lieu of our annual in-person conference for reasons I don't need to explain. Conference usually occurs in June. We've been doing these panels, and today's panel will focus on harm reduction in the age of COVID. Harm reduction, as many know, is the key evidence-based practice in supportive housing, and it remains a core concept of our work. We plan on about an hour discussion, followed by a Q&A. Please use the Q&A function to pose your questions, and we'll field them after the presentation and the conversation is ended. And with that, I'm honored to introduce Diane Louard-Michel, who is the Executive Director of Lantern Community Services. Diane?
I just want to, first of all, I want to welcome everyone to the First Friday series on harm reduction and COVID. I wanted to start off by introducing our illustrious guest. I have to say I'm quite honored to be facilitating a panel with Kevin O'Connor and Nina Herzog. I've known them both for many, many years, and we've gone through many a battle around advancing the principles of harm reduction. So I'll start off with Nina. Nina Herzog has a Master's of Urban Planning and an MFA, has 30 years of experience providing technical assistance and organizational support to CBOs, serving individuals experiencing homelessness, affected by HIV/AIDS, and actively using drugs. In addition to supportive housing and harm reduction services, Nina provides training, grant writing, program design, evaluation, and general capacity building to organizations using evidence-based approaches. And please keep in mind, that's evidence-based approaches and data-driven decision-making. Nina was one of the original dozen Housing Works staff members, starting their harm reduction programs and securing the first ever New York State waiver that made way for syringe exchange in New York City. If you want to learn more, you can just go to LinkedIn and find her full profile. I also want to introduce Kevin O'Connor, who is the Executive Director of Joseph's House and Shelter in Troy, New York. He's worked at the agency for 18 years. And I have to tell you that Joseph's House and Shelter is one of the earliest adopters of what has become known as Housing First. And I do remember Kevin and I go back to those early days. And I'm really appreciative to have his wisdom and his expertise. Before moving upstate, Kevin previously worked in various homeless services programs in New York City. Kevin is currently the COC chairperson of the Rensselaer County Homeless Services Collaborative and serves as an upstate representative on the board of directors of the Supportive Housing Network of New York. So please join me in welcoming our two panelists, and please get ready for a really robust and maybe even rollicking conversation between the two of them. I did want to just say a little bit of housekeeping. I noticed when I signed on that a few people had signed on and introduced themselves. I want to welcome everyone to say hello to the many people who I think are joining this, this webinar. Please just, if you can, and you have the time and you have the inclination, put in your name, put in a title, put in the organization, put in the area that you're from. All of that is rich information, and we just welcome you. All right, so with that said, could we maybe look, I just want to frame it. This is really a discussion or a conversation. It's not a full out webinar about everything there is to know about harm reduction. what is going to happen is we're going to do a very brief framing set of slides, half a dozen slides or more. We're going to lay out the basic principles of harm reduction, some of the myths that are surrounded with harm reduction, and then we're going to really take advantage of the expertise that we have in the room. So if you could start the presentation, Kevin will kick it off.
All right. Well, I'm really honored to be on this call. And I see that 317 viewers. It's terrific.
Yeah, that's amazing.
So again, I'm Kevin O'Connor. I'm the Executive Director of Joseph's House and Shelter. Our mission is to provide non-judgmental services to end homelessness. And today we're going to be talking about harm reduction during a pandemic. And there's a lot of components to that. We thought we'd start out with just a few primers. The definition I like to use is the Harm Reduction Coalition's definition of what harm reduction is. And it's what they call a set of practical strategies to reduce the negative consequences of personal behaviors. It's a pretty broad statement. And I think most of us could recognize some of that practices in our own lives. If we use sunscreen before, if we used a seatbelt in an automobile, if you smoke and there are cigarette filters, those are all harm reduction approaches. Not telling you to abstain from any behavior, it's reducing risk in that behavior. Also, most of us know in our work in supported housing about clean needle exchanges, distribution of condoms, and also during the pandemic, wearing masks and social distancing. These are all examples of harm reduction. Housing itself is an example of harm reduction, and particularly how we practice it as housing first. In 2000, we think 2002. Don't quote me exactly the date. We had the Harm Reduction Group, Harm Reduction Coalition, come up to visit us here in Troy, because for more than a decade we've been providing what we were calling then low barrier housing or non-judgmental housing or safe haven housing. There's a lot of terms to it. I think it's the term now that we all accept is called housing first. But when we met with them in the early 2000s, we had a couple. What is the framework? What are the underlying principles of harm reduction in housing? And I think those are important to review, because a lot of decisions we make on a daily basis in our housing programs to best serve our tenants really tie back to these principles. The first is that harm reduction, works to minimize the harmful effects of people's decisions rather than condemn or ignore them. The decisions that folks make about substance abuse, or how they cope with trauma, or how they're coping with a mental illness, or other circumstances in their lives. And we don't ignore that some of them have real negative consequences, and we don't ignore them at the same time. Our job is to minimize their harmful effects. And secondly, it recognizes that some ways that individuals use drugs or cope with mental illness are clearly safer than others. We understand that substance abuse, untreated mental illness, and other circumstances are complex. Living in today's world is complex, and there are many ways to cope. And clearly there are some ways that are safer than others, and we acknowledge that. The third is that we focus on the quality of life for the individual and the community, and not necessarily cessation of drug use, substance use, or treatment compliance as criteria for success. A lot of us are looking at measures of success as housing stabilities, reducing reentries into homelessness, improvement of safety in their lives, and routine. Those are all improvements in quality of life, and not necessarily succession of drugs and alcohol or treatment compliance. Next slide, please. We also call for non-judgmental and non-coercive provision of housing to vulnerable individuals who who use substances or avoid psychiatric treatment in order to help them to reduce harmful behaviors. This is probably the most challenging component of the principles of harm reduction. We are judgmental beings. I'm going to say that, and that we each have biases, and those biases are formed by a lot of circumstances in our life, our earliest experiences in life, how our immediate families treated us, how we were gratified, our needs were gratified or weren't, the trauma that we had occurred, also our interactions with society. How did our society view us as individuals or as groups? And how much trust in institutions were supported? Were they trustworthy or were they suspicious? All of those form our judgments. And when I speak to my team about our mission statement being non-judgmental, providing non-judgmental services and homelessness, what I mean is that the first task is for us to recognize what our biases are and to keep those biases in check and work on those biases and prejudices so they don't contaminate the relationship. And the non-coercive part of providing housing is important too. That recognizes that each individual that we serve has strengths and capacities, and they have the right to make their own decision. In social work, it's called self-determination. And I think that's an important component or foundation of harm reduction, which also leads to the fifth principle, is that we affirm that tenants are the primary agents of change. It is client-centered. We try to go at where our tenants are. We practice what's called motivational interviewing. Many of you have practiced that, continue to practice that. And when expressed with intention by the folks that we serve, the tenants that we serve, we support their efforts in recovery. But again, we don't coerce that as a condition for living in our housing. The sixth one is really important, that harm reduction recognizes and affirms that there are realities. There are realities of poverty, there's realities of racism, realities of social isolation, realities of experiences of past trauma, and sex-based and gender-based discrimination and other inequities exist, and they affect both people's vulnerability to and capacity for effectively dealing with self and community harming behaviors. We recognize there are systemic flaws, there are cultural injustices that lead to circumstances that create homelessness for most of the people that we serve. And then finally, that harm reduction does not attempt to minimize or ignore the real and tragic harm associated with substance abuse and or undertreated mental illness. Many in our programs encounter tenant deaths at earlier ages than the average life expectancy. The National Alliance to End Homelessness estimate that the average life experience for somebody who has been on the streets for at least a year and has a disabling condition is 53 years of age. That's about 30 years younger than the average life expectancy for the average American. So we know that some choices, if they are choices, have real and tragic harm associated with them, and that we don't attempt to minimize or ignore them. We know that, again, this is a reality of the work that we do. Next slide. This, I just want to go through a definition, a quick definition of housing first. Many of you practice it. Again, the National Alliance to End Homelessness define housing first as an approach that centers on moving people quickly from the streets or shelters into housing as quick as possible, and then providing services as needed in the housing setting. And it is housing-based, not treatment-based. Again, our measures of success are the quality of improvement of a person's life, housing stability, and helping people to make the best decisions they can in housing. The next slide, please. The corporation-supported housing, break that down to three simple components. One is that for our housing, there needs to be a simple application process. Um, each coordinated continuum of care has a different process. We have what's called no wrong door up here in the Capital District, where people can go to any numbers of places to apply. The applications are based on facts. How long have you been homeless? Do you have a disabling condition? Do you have multiple disabling conditions? What is your age? Um, um, are you a veteran? Are you a woman who's pregnant? Are you youth? And there are other vulnerabilities that we rate on a vulnerability index that gets prioritization for housing openings. But it's a fairly simple and factualized process. It's not an assessing process. It's just a validation that you are homeless and your current life circumstances. And second is that harm reduction approach in which the tenants are not required to be sober or treatment compliant in housing. It is not a prerequisite that they are abstaining, that they're enrolled in any kind of services, or that they're even participating in on-site services or agency-based services as a condition for residency. And finally, that there are no conditions of tenancy that exceed the normal conditions of any leaseholder would be subjected to. And that includes a participation in treatment or services. So we thought that would be good opportunity for us to first start out in what we define as important components of harm reduction in housing first. Now I'll pass it over to Nina.
Okay, thank you, Kevin. And Shinny and all my friends everywhere. It's really, really nice to be with you. I wish I could see everyone on the call because I feel like I probably know a lot of you. So yeah, my name is Nina Herzog. I use the pronouns she, her, and I'm going to talk about some myths that that are commonly associated with harm reduction. So one is that harm reduction is pro-drug use, and harm reduction is not pro-drug use at all, right? It's harm reduction takes a neutral stance towards drugs or substances in general, substance use, because harm reduction is a public health approach. So we understand that substance use has positive aspects and negative aspects for everybody, right? So for everyone here who has, we all know the positive elements of substances, right? Like, so how many of us on this here today wake up in the morning and the first thing we think about is a really good, strong cup of coffee, right? And it is not just for the taste, right? It's because we just want that boost. We want to wake up faster than our body makes us wake up. That's what we do, right? And that's how, yeah, someone's saying me, ha, ha, ha. Yeah, me too, ha, ha, ha. And how many of us obviously routinely end the evening with a glass of wine or whatever it is, and particularly during these COVID times, right? Where we're all sort of always doing the best we can with what we have. So we take no position on drug use, but we do very, very keenly look at, for each person in their situation, what about this drug use? What about this substance is positive? And what about it? So what about it? What impact does it have on your life that you like? And also, what impact does it have on your life, or your life, your loved one's life, and the community, i.e. what harm or risk is involved that you might want to mitigate or reduce? So those are the conversations, right? So since it is a public health approach, it is not a moralistic approach. It's not about this is better than that. It is just this acknowledgement that people have always used drugs, always. People have always used substances everywhere. There is no block on New York City. There is no apartment in New York City where you can imagine moving to where people aren't using substances, right? We all use substances. Next slide. Harm reduction takes the responsibility off the drug user. And so nothing could be farther from the truth, right? So in fact, harm reduction derives its success. And by success, I mean it's evidence-based, right? So we know through research that harm reduction is the most effective way of working with active substance users. Its success is really centered on this idea that we are perfectly in tune with the notion that the person using the substance is the person who has all the information, who has the most accurate information, and is the most capable of making change. So when we're working with people who are using substances, they are the experts of their situation. Just like when we work with people who are experiencing intimate partner violence, right? We know that you never want to, I'm going to say she because that's most often the case, but you never want to push a woman to leave a relationship before she's absolutely ready, because no one knows as clearly as she does what her level of risk of being murdered or killed if she leaves that time is, right? So people have, I am the keeper of the most important and accurate knowledge about myself, about what I need, about what I can handle, about what goals I might be able to achieve and what goals I can't. And one of the strategies that's so critical here with harm reduction is setting small achievable goals. So who is the person who's going to be able to tell anybody what goal is small and achievable for me, right? And that's how harm reduction helps us change our relationships to substances by beginning to slowly start to accumulate wins and successes and control over this relationship we have. So it's all about really helping the person understand and deepen their own relationship with the risks and the positive aspects of their substance use. Can I get the next slide? Cool. Harm reduction encourages drug use. So the best way to answer that question is really to just go to research, right? Which has shown over and over and over again. There's so much great research in Canada, actually, where their health system, their public health system, is more universally harm reduction. And again, it's really important to say that it may very well be true that Kevin and Diane and I and Shinny believe in harm reduction. But that's not why we're talking about harm reduction, right? We're talking about harm reduction because it is the most successful evidence-based intervention or approach to dealing with and engaging people in reducing harm, the harm to themselves, their loved ones, and their community around substances and their substance use. Yes, so no evidence at all. In fact, harm reduction is the most likely way, most successful intervention for reducing drug use and reducing harm. And I think that's it for myths. I mean, there are a lot more, but that's all we got for today.
Well, thank you. Listen, I'm coming back on. I already feel like we've gotten a lot of rich information from both Kevin and Nina. Excuse me. I am interested though in turning back to some of the themes that Nina, excuse me, that Nina brought up. One of the things as I look at the evolution or the adoption, increased adoption of harm reduction and housing first as a principle, I think that we get very caught up in the sort of the methodology and how to do it better. But there is this framework, I think, of public health. It is basically, as you said several times, a public health intervention. And it's a public health intervention with many sort of evidence-based principles and also integration of different evidence-based models. If you could speak to that a little bit, Nina, I'd appreciate it. I'd also like you to think about how does that tie into this COVID pandemic, where it's the biggest public health crisis that we have seen in our lifetimes. How do these different public health interventions that are evidence-based and have been proven, how are they stressed, or how are they really helpful at a time like this?
Yeah, no, that's a really great question. So there are a couple of things. One is that what we've introduced today so far, right, Kevin and I and you, are these principles that underlie it, and sort of stressing, like we said, that this is a public health approach, right? This isn't just it's not a religion. It's not you know what I mean? Although it certainly has a set of principles and values underlying it. But on the other hand, it is a set of strategies, right? Like there are actually tools. There are, like when I was talking earlier about the question of like engaging people in conversations through motivational interviewing or whatever about, the possibility of changing a behavior or looking at a behavior, and thinking about using decisional balancing, for instance, right? Where people literally sit down and they write, they have a box, right, that says, here are the benefits of use, and here are the not benefits of use, right? Here are the benefits of changing, here are the benefits of not changing. And with each goal going through that, like, so that's one thing. I was thinking of another thing and now I completely forgot, but it'll come back to me. And to the question of, oh, I know what I was going to say. Another thing we think about, just a very simple way of breaking down how to think about strategies, right, is the elements of risk are really important, right? So the elements of risk, there are many, but fundamentally you might think of like route of administration, dose, quantity, and environment. So when you're looking and you're talking with somebody about their behavior, and that's the other thing that's really helpful with harm reduction, is you don't want to, you're not talking about with everyone their substance use, your drinking, your heroin use. You're talking with them specifically about the behavior, right? This is much more helpful than talking about your terrible substance use, which they feel most likely a lot of shame about, way more than you and I are gonna like suddenly instill upon them. So talking about the actual behavior is productive. It's a thing. It's something you can discuss. It's quantifiable. It's finite. And then in terms of the question of COVID, I think the impact is, I was just looking, it's interesting. New York City has just, has its naloxone, its Narcan kits now include masks and a whole separate set of instructions, right? About, that begin with, okay, so if you're going to reverse someone's overdose, you're most likely going to come closer than 6 feet, to them. So first put your mask on, and then, follow the usual steps. And then other things that we have to think about, and the reason I noted the elements of risk is that a lot of the people we work with engage in underground street economies, right? Both to get things that they need and to get, both to procure things and for resources. And there are lots of reasons for that, right? That make sense, and some of which are driven by social determinants of health, some of them by structural racism and homophobia and transphobia, right? So many of the trans women of color we serve don't really have much option other than sex work and things like that, because it's really difficult for them to be employed in what we call, I guess, like whatever, like regular employment or something like that. So people are, so risky behaviors are made even more risky right now. And that's one of the things where we're really noticing. We're certainly also noticing that the obvious effects of isolation. There's a huge spike in overdoses. That's a big deal. And let's see what else. And of course, just, one of the things that COVID has really revealed is even more highlight on our existing inequities and injustice, right? Everything from, the horrifying, constant, every single day murder of Black men and women, and trans women and trans people. I mean, it's kind of stunning and overwhelming, and yet it's always been there, right? But now we see it. But we certainly are seeing the degree to which COVID, right, the people who are helping, the people who are essential workers, and how much white people, how much easier it is for them to remain safe. So yeah, I don't know if that's a sort of a rambling, but
Yeah, let me.
I'm going to let
build-
Kevin pick up because
Yeah,
I think
let
he
me
has a
build on.
couple.
So how does that affect you? So we have 208 tenants in both site-based and scattered site apartments, and how does that live on the ground today during the middle of COVID? Well, let's go back to March and April, when the world was telling us that we should wear masks and social distance and wash our hands incessantly. And there were still lots of questions, but those things were the earliest recommendations. If you had a cough, you should go to the emergency room. All those kind of things that came up. And there was a lot of confusion at the time, but there were things that were clear, and there were recommendations. Well, in our programs, we respect client choice, tenant choice. At the same time, our staff's going in and we're working 24/7 in all of our places. We're wearing masks, we're keeping social distance. And our tenants may not be making that same decision. And in fact, we got some instructions. OMH funds some of our programs and say we cannot require our folks to wear masks or social distance as a condition for receiving services. And certainly we appreciate that. But so it puts staff in an interesting position because they have their personal lives, their personal safety to be considering, and at the same time, the tenants that we work with are not practicing some of those safe behaviors. So it really pushed us a bit to remember that it's choice, that we will give people information, and that's the important first step. How are we going to communicate in the middle of this pandemic to all of our tenants? How are we going to give them information that's factual, that's not coercive, but highly recommended for you to stay safe? And at the same time, respect their choices, because people have different capacities, and we deal with folks that are coping with a lot of circumstances. We have a lot of folks who are thought disordered, and some folks who are fairly paranoid about wearing masks or seeing other people covering their faces with masks. We have other people, interestingly enough, one person suffered third-degree burns on his hands because he was incessantly washing his hands, because that's all he was listening to was this horrible COVID and pandemic and the death count that's happening in the state. And he was so afraid of dying, he was just washing his hands, keeping the hot water in his hands under the whole time. Right? So we need to, in the middle of this, and that was one of the first things we did, get all the teams together at the different buildings and say, we still need to engage. We still need to have one-to-one conversations. We can't be afraid of our tenants, even though our tenants are not practicing those same protective behaviors. And that was a hard ask, very, very difficult ask. And I think that it was successful. I think in all of our programs, we had one person who tested positive, who's a participant. We've had three staff members through community contact who tested positive. So I think we've been fairly successful, but I think that individual approach still has to be maintained, and that we as workers, the hardest part of housing first, I think, in harm reduction is our own biases. And we can intellectualize and say, okay, I'm going to accept this person's activities with drugs. I'm going to accept this person's refusal to take psychiatric medications, or I'm going to accept this person's behavior around sex trade. When it comes to our own anxiety, when we are anxious, that's when some of those biases come. We don't have that same filter. And that's why the head to heart is a struggle as case managers and direct service providers in this work, that we have to do the best we can to stay safe, to practice safety ourselves, to make good choices, but still be as engaged with folks as individualized as possible. And it's hard. It's hard. I give kudos to the 350 people who are on this call. You're all heroes. And go back March and April, those sleepless nights we all had about our own safety and our professional responsibility to clients, and particularly when we're working in a housing first model, which respects people's right to make their own decisions, and really focuses on the most vulnerable people in our communities moving into housing to end their homeless experience. So kudos to everyone. I want to give another example, which is interesting, and it really pushed our staff to really look at harm reduction and the principles of harm reduction to make the best decisions on the behalf of our tenants. Right away, we suspended visitation into our buildings. We suspended our volunteer program. We platooned our staff so that there was just the essential staff that was going in, the cleaning staff, the kitchen staff, maintenance, and the direct service workers who needed to be there. And so we really limited the folks that were in at any given day. And then slowly we increased that as things got safer, but we hadn't reintroduced visitations. And went by one of our buildings one day, and there was a whole mess of our tenants hanging around in the front of the building. And we did a little discussion about that, and our impression was there was a lot going on in the community. Our tenants were doing drug transactions. They were involved in the sex trade, or they were just hanging out there with their visitors on the street in the middle of a heightened gun violence is happening in our neighborhoods. And then so we had to figure out what is safe here. What is the harm? What is the least harm that we could do? Staff was very anxious about introducing visitors back in because we've done a very good job of keeping COVID out of our buildings. They were concerned both for the tenant's sake and their own wellness. And yet, they all acknowledged that people weren't doing as well personally. And that was, there were folks that were getting tangled up in stuff on the street that normally wouldn't have the privacy of their home. So when we looked at harm reduction and we looked at what is the safest thing to do, midsummer we decided to allow visitation to happen again. And we know that risk for the contagion, and I'm knocking on wood. At the same time, however, that the folks had the privacy of their homes to conduct whatever business and choices they were making in their lives. They had staff that were present in case there was a crisis in their lives. The folks were less isolated. Family members, significant others could visit on a limited basis. We limited the hours and how many people could visit at any given time. And that helps reduce. That helps reduce the emotional isolation. That helps reduce some of the unsafe behaviors in folks with involved in the sex industry. Unsafe behaviors around drugs. And so that's the balance. That's the balance that we have to look at with harm reduction. So those are a couple of examples I wanted to lead off with.
I'm glad you brought them both up. We did discuss this a little bit in our pre discussion, and I just thought that that particular example was particularly provocative in terms of, you know, the intuitive response versus the let's consider all the variable
Yeah,
response.
it's
And then
tough.
let's just like we're talking about reducing harm, it's also about how you do risk mitigation. How do you balance risk?
Yeah. And it's tough, Diane, because
Mhm.
you know, our staff is our greatest resource, obviously,
Mhm.
and we've got to get buy-in from our staff. In order to do that, it's going to be rooted in fundamentals and principles, and in ethics too.
Mhm.
And least harm is one of the ethics I think that we should be practicing. And sometimes it's a head and heart divide, and we have to deal with that and support
Mhm.
folks, our staff, when we're in that space to be able to do that. I think that's a lot of our work as supervisors and program managers, is to be looking at the fidelity of housing first and harm reduction and supporting our staff during a very, very difficult time.
Mhm. Right.
And if I, can I add something?
Yes, I was going to ask you. Okay, go ahead.
Yeah, no, I was just looking at some of the comments, and Carol Lemus made asked a really interesting question and made an interesting point.
Mhm.
And she's asking, right, about this question of individual choice versus common good. And
Yep.
I think that's kind of where we are right here. And one of the things that's really important about harm reduction and its principles is that it engages the community as well, right? It is self-determination, not only at the individual level, but at the community level. So partially when you come across this rub between what is good for the individual and what is good for the community, ask yourself if this is a question you should be answering on your own, or is this a question that you should be putting to the community in a greater way, right? So if there is some policy decision, and if you've sufficiently, hopefully, sort of gotten buy-in, not just with staff, but also with tenants themselves, then a lot of these questions are really, really important questions to bring to your tenant association meetings, right? So that's really important for us as staff, right? These are not, we should never be in the position of dictating to people how a community runs and whatever. And of course, to some degree we are. We have budgets, we have laws, we have, I'm not talking about in those simple ways, but in the more complex ethical issues, often when you go to the tenants, they are the experts, and they have the creative responses as to policies or whatever it is. So
Yeah.
I just wanted to offer that as
And
another way of thinking
I'm
about it.
I'm totally in agreement with that. And a challenge during the pandemic is getting those tenant meetings together, because we have not. None of those tenants in any of our buildings is together. And I love going to those meetings before. There was seldom agreement, but there was always good exchange of thoughts amongst the tenants. It's not me disagreeing or agreeing, but amongst the tenants themselves. And we missed that. So we had to find out ways to get input differently. And some of it is individual. We had little surveys that we ask people individually. We have a little board too for people's suggestions, and we asked them about things like visitation, such like that. And there were folks that were really opposed. There were tenants who were really opposed to loosening the visitation policy, for instance. And there were folks that were really, April the 1st, they were asking, when are we going to allow visitors again? But you're right. I think that we need to get the say of the people who are closest to the circumstances, whose life are most impacted, and get their input. And we need also to make the decisions about the impact that it's going to do to the most vulnerable amongst us. So that's another element of the question that ethically we have to deal with. It could be an unpopular decision by numbers, but looking at the most vulnerable person in the community, is that decision going to serve that person or hurt that person the most? Who's going to be hurt the most or most impacted by the decision or non-decision that you need to make as a team? Teamwork is very important. We don't make a single decision as a single case manager or advocate or a program director. All of our programs meet regularly. That was an interesting challenge because we always had it face to face, and we all had to figure out. At first, we were doing freeconferencecall.com, and then evolved into Zoom. But it took a while for that to happen, and so we missed that at first, and we struggled to get input. Communication is very important, both with the service providers as well as the tenants that we serve. I agree totally with that. Yeah.
I want to interject with another question that comes up. So one of the things that, I'll just start with a small anecdote. I found that at the beginning of the pandemic, we had in some of Lantern's buildings, people not really understanding social distancing or mask wearing. Just be like the way humans respond to behavior. It seemed to become much more applicable when they couldn't go to the bodega and get whatever they needed. They were actually like being banned from the business. That was like 2 weeks later, but that resonated. And I do think that in other buildings, there was just an understanding that Black and brown people and poor people and homeless people just like them were actually somehow even more vulnerable. And so there was that. So, so those are just two little anecdotal, things. I think it does bring up, how does environmental factors, not necessarily what's directly in your building, but, this larger environment, how did that impact, I think, the people that you're serving through the harm reduction and housing first model? Did you find that there was some uptick, or some sort of modeling that had to be not just about the program and the service delivery, but the environment? And that would also extend to social justice. And we'll take that to that'll be the next place we take it.
Yeah. So so yes, it certainly did. We were already living in the world that was looking at systemic racism and injustice that was occurring in the world when the COVID broke out, and it intensified during it. And we in upstate New York, and I believe it's also the same circumstance in the city. It's been a while since I worked there, 22 years, I think. If somebody is in immediate danger to self and others, and staff is in agreement that this person's really not doing well. We have a bunch of programs where we get Office of Mental Health support, and all of the all of the tenants in the programs have to have a severe persistent mental illness and a chronic homeless history. So folks have pretty extraordinary vulnerabilities, at least coming in, and there are times when under stress that people need a custodial setting temporarily for their safety or the safety of others, and that happens. We rely on this system on a couple of systems. One is our what's called mobile crisis teams, who are mostly social service teams that come out. And upstate New York, mostly those are for folks to receive a service. They have to be voluntary recipients of services. And there are a number of times that we're working with somebody who's imminently threatening, and they're not going to be voluntarily receiving outreach services. So the next level, I'm saying unfortunately, I think the police would also say unfortunately, is that we have to call 911, and the first respondents and the respondents that could force a person to be evaluated against their will in upstate New York are the protective services, the police workers, and that's a loaded issue. Police themselves are feeling the pressures of Black Lives Matter movement and all of the close watch that they're under these days, and they're getting really anxious about responding to these calls. And what we found is they under respond to these calls now. And then we've got the population that we serve in upstate New York, about 40% of those that we serve are persons of color. And they have particular feelings about police intervention. So we've got to be creative. And I know there was a workshop last week here on Shinny, on the Shinny Friday, that talked about bystander, that talked about alternatives to intervention. But during the midst of the pandemic, that's what we had. We no longer had a crisis, mobile crisis. They were just doing remote interventions, which for many of our folks doesn't work at all. And they were also getting very, very lax response by police. So it was sort of a team approach, an individualized approach, a listening. Tell me what's going on. And yes, a person's really agitated, and agitation is not a reason to hospitalize somebody or call the police. Being very clear, and in some ways de-escalating our authority. Just say, we're here with you. We're not going to touch you. Tell us more about Jesus's blue blood coming through you right now. Tell us more about the angels having a soccer match in your head and you wanting to jump. Tell us more about that. And then hopefully work into a voluntary step that we can voluntarily engage them with mental health services and crisis services rather than the police. Up here in upstate New York, in Troy, we had a Black Lives Matter rally in June, maybe July, 11,000 participants. And all of downtown, not all of downtown, but 90% of downtown boarded up their buildings. We have a lot of buildings as well as other providers do downtown. And we decided there's no way that we're going to board our buildings in fear. We have to engage. We have to be a component, and our COC is working as a component now in the community to address not only service delivery in our COC and the bias that's implicit and explicit, but also to our community as well, and engaging with police. This morning I was on a call, and we are planning a training with police officers, with our mental health providers, homeless service providers, domestic violence providers, OMRDD, persons with disabilities providers, and expert Sergeant Weaver from upstate police department, who does this now, doing trainings with the police, and it's a week-long training, and we have essential components of that to talk about from our homeless services provision perspective, how we need their services, but also how there's ways that the service can be delivered that's also detrimental to the folks that we deal with, and we have that's scheduled for the second week in December. So we're looking forward to that. We've been a part of that before. So it's not just, as you said, Diane, very well, the environment. It's not just the environment within our buildings, but it's the communal environment as well. We used to attend all our neighborhood committee meetings. Of course, those aren't happening in person anymore. To dispel the myths of homelessness, to dispel the myths of harm reduction and housing first. We'll never convince everybody in the community. There are some people that are watching us like a hawk, and anytime any of our folks cross a line, I get emailed, which is fine. We want to encourage people. We are not your typical neighbors, but we like to be responsive neighbors. And if there's things that's going on in the community that is upsetting, then again, in a harm reduction approach, it's important for us to do whatever we can to help mitigate that harm.
Kevin and Nina, I want to ask a question that I think is related. It's come up in the Q&A. Natalia asks, I notice sometimes dealers will prey on folks with SUD in the streets near recovery services. Do you have any ways to tactfully reduce the harm of these predators? I have a feeling that there's more than one of us providers in the room who are trying to grapple with that.
Sorry, can you repeat that really quickly?
Okay, I will say that one more time. Sorry if I wasn't, what didn't come through. Natalia says, I notice sometimes dealers will prey on folks with SUD in the streets near recovery services. Do you have any ways to tactfully reduce the harm of these predators?
Yeah. Oh, all right, Kevin, take it away.
So, so we've been running this housing, oh gosh, almost 30 years now. And certainly early on that occurred. And there were some really, bad circumstances where visitors were dealers, and they would go down the hall and try to engage other people and take advantage of folks and such. What the tenants decided, and each of the tenants groups have agreed to, and been practicing for a long time now, I can't remember how long, is that all visitors, the tenants wanted all visitors to produce identification when they came into the building. And it's interesting because just asking that really was a screen. And again, it's not something that staff, we didn't come up with that. Staff didn't suggest that. The tenants did, because the tenants were concerned either for themselves or the most vulnerable tenant down the hall that they had. Now, again, this intervention doesn't work with scattered site as well. It can't work with scattered site. But on our site-based, I think it's worked fairly well. We haven't had many exploitive incidences. It's been a long time since I recall that an incident coming up. And it's been an effective intervention, and one that the tenants themselves decided.
I have sirens in the background, so I just want to ask, Nina, is there anything you'd like to say about that? If not, I'll try to go to the next question that popped up in the chat.
Yeah. I mean, there, two things. I also wanted to respond to the environment question earlier. When I was mentioning environment as one of the elements of risk, by environment, I meant everything from like how much light there is where people are using, safety in terms of who you're using with, and obviously harm reduction goes to sex behaviors as well, both in sex work and obviously transmission of AIDS and HIV and other sexually transmitted infections, and also, what does that word say? Light, safety. Oh, arrest. I was like, unrest. Right. Another element of that is how people can use drugs or substances safely without risking arrest, right? Which, if you live in a neighborhood that is much less, right? White people use drugs at exactly in fact, all people, all racial, everybody, every kind of people use drugs at exactly the same rate. The only cohort we know that exists that uses drugs more than anyone else is youth. And that's because they're experimenting. They're learning who to be, how to, whatever. And that's across all things. So, but when you live in a community that's very heavily policed, one of the things that harm reduction includes in terms of environment is how to mitigate the reality of structural racism in your community, and that you're much more heavily policed than other people. So you talk about how to not be arrested when you're doing your things, right? Like that is a conversation you have to have. And the other thing,
let me pop in there because I got a good
right.
example. And it's an individual example. We had a person who, before she moved into our housing, had 54 arrests, all for her activity in the sex industry, the sex trade. And we moved her in, and she's been in our housing 12 years and no more arrests. Interestingly, though, and again, she came up with this. She had some of her, let's call them guests, that she didn't feel safe with, that she didn't feel safe with, or the neighbors in the building didn't feel safe with. And so we had a chat with her about that, and she said, I love this housing. I don't want to lose this housing. What can we do? And And her asking, what can we do? The motivational interviewing hat ears prop up. And it's like, what is it that you want different? Well, I want it to be safer for everybody. I want it to be less crazy for me. I want to be safe here in the building. And long story short, we agreed to her, and she's practiced this for, God, 5-6 years now, that she is going to develop a predetermined list of visitors. This is just her. This is what she has decided for us, and she wants us to enact this protocol. She's going to submit a predetermined list of her visitors at the first of the month, and those are the only visitors that she wants us to allow in to visit her. And at the end of the month, she can change that to another group, but it'll be limited to 5. Right? So interestingly, we are reducing harm. We're reducing the number of partners that she's engaged with. And interestingly, over the course of many years, some of those partners, we don't think were sexual partners. They evolved into friends that were still coming and visiting her. And we threw a lot of condoms at her all the time. And we had staff in the building. So if there was a problem with one of her guests, she knew that she could come downstairs or call downstairs and there'd be some help, because we have 24-hour staffing here. So you mentioned before, the reason we're talking about this, again, this is an extreme example of an individualized plan that we had with somebody involved in the sex trade. Out of all the buttons that get pushed, I think for our staff, it's folks involved in the sex industry and sex work. And I'm not sure what that is. Other people's buttons are mental illness. Other people's buttons are IV drug use. Other people's buttons are domestic or relationship violence. But I think the one that pushes the most buttons in our staff is around sex work. And I think we have to, again, in our head, talk about as a public health problem. It's important to help people reduce that activity if we can, and to do it safely when they're engaged in it.
Yeah, a couple of things. One is that we also have to remember we are not, nor are we never will be, nor do we need to be the experts in every field. So there are lots of organizations out there made up of sex workers who know how to keep themselves safe, right? Unless any of us on this panel here are sex workers, we may or may not be, but we're probably not going to say it right here. But we don't know, actually. We are not the experts on how to stay safe. You can bet your patootie that the people who know best how to survive on the streets while having to turn tricks are sex workers. So they are the experts. Those are the people to whom we should be turning to ask and to help people stay safe. There is a way. Sex work also has existed since the dawn of time, and many people don't want to be doing that. It is a forced means for some people. Some people do it with a tremendous amount of empowerment, and other people because they have no choice. But it is a choice ultimately that people make because they feel they need to, and it is sort of beyond us to. Anyway, yeah, that's it. Oh, Diane, you're muted.
Muted.
Okay. Third time is a charm, okay? I'm checking the chat as well as the Q&A. And I just wanted to pick up on a question from Lisa. She asked, any practical tips for how to remain non-judgmental, non-reactive while engaging in harm reduction with clients?
Don't
And
do
I'm
it
kind
alone.
of, and I think that's a message that's come up so many times as a challenge.
Yeah.
I don't know if there's anything else that you want to say about that, but
Nope.
directly to people who are working with their clientele.
Don't do it alone. Don't do it alone. The importance of teamwork in this model is really important. Making decisions, reactions. We don't want all that weight. It could be a crushing weight of what's going on, what you are experiencing, the trauma that you are experiencing in other people's lives, and that's being shared to you. And our own biases that I talked about earlier in this call. It's important to do some of that work privately, and it's important to do some of that work professionally. And I think the professional work should be the team leaders, the supervisors having discussions about what are your pet peeves. Again, not in a private meeting, not with tenants, obviously, but what are your pet peeves in this work? What do you think your biases or populations could be? What do you think your strengths are and the population strengths? And I see that you work really well with men who are previous sex offenders. How do you do that, Harry? And how are you able, Harry, to sort of be patient and to be affirming with that population that really triggers me? So that one is teamwork, and the second, even before that, is a foundation, an approach. Whether your mission, your vision, your values are clear within your agency and within the program. What is housing first? And don't like to use a snowflake analogy too much. First of all, it's snowing here right now, but also, there's a political thing with snowflakes right now. But I believe that each agency, each person is as individual as a snowflake, but each agency is as well. We all have unique histories. Our agencies have unique histories. Our agency started as a homeless services provider. So we got very early into this kind of model because we are a homeless services provider. Other agencies that you work in may well have started out as a child guidance program or a housing development program or a veterans program or a substance abuse program. And the transformation of housing first is extraordinary between a lot of how we were initially professionally raised. I know it was for me at first. And I think that's the other part of it, that the programs have to be clear in their mission, their vision, and their values, and their practice about how to make decisions. Nina, anything to add on to that?
Yeah, I would add, if I could give everyone a t-shirt, what the t-shirt would say is, everyone is always doing the best they can with what they have. And you may not see it, and you might run into me someday, and I may not look like I'm doing so good. I have had days, times, periods in my life where I'm not doing so good, but everyone is always doing the best they can with what they have. And that is absolutely true. And it's just a simple notion, but if you can kind of remember that, it may not look like they're doing the best they can to us, but in fact, they really are. So yeah, that's the t-shirt.
I put in the chat that I want that t-shirt, Nina. So we might have a new cottage industry that we could start.
Yeah, organismically, even like, just for 1 minute, organismically, humans, all of the decisions we make, they're all calibrated to safety. So this is the best we can do at any given moment to keep each other safe. And it might not be obvious to us or to others how we came to those ideas.
Well, I will say this, thank you so much. I want to say that the chat box, the Q&A box is just lighting up. I'm going to try to sort through some of the questions. One of the things I wanted to ask, someone asked, what are your thoughts about using MAT, medically assisted treatment, as a harm reduction strategy for those that struggle with persistent relapse in housing?
Totally in favor of it. In fact, several of our tenants are engaged, Suboxone or methadone, the other treatments coming out. Totally in favor of it. Harm reduction. It connects with a professional on a regular basis who's encouraging, who's a listening person and who's encouraging people to make safer decisions. It's tough. Anybody that's been dependent on a substance knows it's very, very difficult to stop. We have 60% of our staff who are former recipients of services, similar to our tenants. And we know that our staff sometimes have struggles with it. We have an EAP program that we engage a number of our staff from time to time with it. We know it's hard. We have to use all the tools available out there to help. And totally in favor. Nina?
Yeah, ditto, 100%, and highly effective. And when you think about opioid, we're really, really lucky. We have the ability to take it from terminal to unterminal, right? To save lives. We have the ability to take pills to really reduce cravings. There's a really remarkable medical advances out there.
Oh,
and let me add one more thing. For upstate New York, it's really a health safety. The fentanyl overdoses are off the charts over here. We've had a 60% increase in fentanyl overdoses so far, and we're only 3/4 of the way through the year. And so if somebody's on monitored MAT or other kind of Suboxone or other kind of thing, we know that's safe, and they know that's safe. We also have been passing out tester strips as well to our folks here to keep safe.
Excellent. I have another. I really am trying to kind of pull out the questions that are top of mind for practitioners. So Sarah asks, can you speak to some of the different tactics of practicing harm reduction in scatter site housing where access to clients is more limited? And I do know that you run some scatter site, Joe. Kevin.
So engagement, yeah, we do both. Oh, almost exactly half, maybe. I don't know. I lose track. So engagement's the big trick, right? Which everybody that knows about scattered site is. And what we do is try to kill people with kindness. We try to get into their house frequently as possible. Right now, we're meeting people on the porch. We're not going into homes. We need to talk about that. Apartment visits are an issue during the pandemic. We're anticipating and asking them what their needs are. So we're going into the households and delivering a lot of food. We are getting kids tablets for their school. We are engaging people with Thanksgiving and Thanksgiving meals. Again, not communally, but on an individual basis. So every month or two, we've got a big kind of visit gift in order for us to get into somebody's household to maintain that relationship. We've got everybody's phone number. We're texting people. We're checking on them. We're giving information to them as much as possible. And so community is the big thing. Isolation is difficult, and I think obviously we're not able to monitor what's going on in the household, relationship violence, child neglect, what's going on with isolation and mental health, unless we get into the apartment. So the trick is, what do folks want? They don't want us to monitor them, but they want food. They want supplies. They want face masks. They want a little card to extend their cell phone or cell phone blocks, chargers. Get creative and listen to what they want, and be an instrumental and irresistible part of their life. And that's the challenge with scattered site.
Well, you just picked up on one of the questions that popped up. It's kind of incentives. What do you think about providing financial incentives in order to try to reduce harm?
Yeah.
Yeah,
so that's something called it's called contingency management as an intervention. And there are more and more studies, which I just absolutely love, that support contingency management's efficacy in helping people reduce drugs. So their drug use and risk overall. And again, it's so in keeping with the idea of harm reduction, right? Which is exactly picking up on what Kevin was just saying, which is that there's nothing wrong with with meeting people's needs and giving them what they want, right? I mean, sometimes we have these sort of really, you wonder, like, how did we get here that we thought we should be walking around telling people what to do, and that they should be really, really, really grateful to us that we gave them housing, which we have, and we don't walk around like, I mean, so this is that notion of contingency management, giving people what they want, what they need even more, is really critical. And I think of course, all of these things have to be calibrated in terms of their delivery and things like that, but absolutely.
We have not given out financial incentives for people to do what we want them to do. So it goes against, again, the coercion. Again, money's not coercion, but it kind of is. So when we give things of value out, we give them to everybody in our program. When we give the Stewart's is a 5 and dime store around here, the convenience store around here. When we give people $25 Stewart's cards, we don't tell them what to get, but they can buy alcohol actually at Stewart's, but they can buy lottery tickets too. But we give it to everybody, so we don't incentivize on a financial basis. I think it's a little loaded and a little slippery for us. I respect other programs that do it, but in our housing programs, we do not.
Interesting. There's another kind of related question. I'm sorry. I have to focus. One of them is question about, what do you think about staff self-disclosing to tenants?
So the first training that new employees get at our agency is Housing 101 and harm reduction. The second training they get is professional boundaries. And what we do is, and again, we hire, 60% of our staff's either received services of our program or something similar of our employees. So we have a lot of folks with a lot of life experience. And we don't tell them not to disclose, but at the same time, we ask them, what is the purpose of your disclosure? If somebody's asking, have you heard voices? Are you in recovery? Have you ever been incarcerated? Have you been involved in the sex trade or sex industry? The first thing that we should be asking is, what's behind that question? And typically it's a competence question. Are you competent to understand me and solve my problem and relate to me? And the tools we have in engagement and in relationship is not what my life experience has been, but how good am I as being a listener? How good am I about being an attentive helper? How good am I about being there and following through? That's where my competence comes from. Disclosing your world, and you are a unique snowflake. Remember that analogy? Everybody deals with substances differently. Everybody deals with sexuality differently. Everybody deals with emotional pain and trauma differently and uniquely. It can have an unintended influence on somebody if you answer yes, and I went to this rehab and I got sober through an abstinence model. Well, it sends a confusing message if we are focusing on the individual, and the individual is the expert of their own treatment.
Excellent.
So I have a slightly different response. I support a lot of what Kevin is saying. I also really, really know that the importance of having visibility within an organization of all sort of marginalized identities, and that it's really important when possible, whether that's mental illness, whether that's gender variation and expression, whether it's history of homelessness, being HIV positive, whatever it is, if you have people who feel comfortable disclosing and for whom that is not a triggering thing, right? So that might be done in consultation with a supervisor or with the support of a supervisor or something like that. If that's not a hot button issue for a person, if it's something that they've dealt with, and then there's an enormous, again, I hate to keep talking about research, but I am a research nut. There's an enormous amount of research about on the difference in relationships between one where you feel like the person is a peer in some way, and the effectiveness of peers and the effectiveness of having people of the same identity as you, when that identity of yours, whether it's as a drug user, whether it's as a sex worker, has been revealed.
I don't disagree with you, Nina.
Yeah. I am aware we have about 5 minutes left. And I'm a little bit torn. I'm wondering whether we can get a very quick response to a follow-up question on MAT usage, and then one more sort of tie-off question about resources, okay? Could we try to do it like a lightning round? So let me get this very specific. It says, going back to MAT, Jacqueline asked, what approach would a QHP take with a client with a service history of cocaine use disorder, who is on agonist therapy and not motivated to develop abstinence?
Client choice.
Client choice?
And listen, and at the point where they're expressing their intention to consider change, jump on it. But before that, client choice, right, Nina?
Yeah, and I would also say that, like, here you're talking about care coordination as well, right? So we've got a couple of experts who might be, who might be. So this is one of those great situations where getting on board with the other providers might also be really, really helpful.
Yeah, good.
Great. So I'm now going to ask the final question. There may be some cleanup that tying off that the network wants to do. From Christina, can anyone suggest a good online training for de-escalation training? And generally a good resource for quality online trainings for frontline social service staff, be it anti-bias, active listening, client-centered, empowerment services, mental health 101. And I ask this question because I do think that we're finding both clients and staff to be just a little bit more inflamed, a little bit more hair triggered.
There's a lot more
And so,
stress.
and that's a stress reaction. And so I really want to get to this as a kind of tie-off question. There's something you could possibly also share with the network to be shared with participants, okay?
In upstate New York, I don't know if it's I assume it's available downstate. OTDA has done some great de-escalation training through their professional development workshops, and I think some of them are now taped, but they were live before, and they were initially available for folks who were in homeless shelters and outreach. I think they're now more widely available. I don't know exactly how to get in touch with that, but that's our staff. Most of our staff have attended those kind of trainings.
Yeah, I'm less in touch with training resources these days just because I do so much of it myself. But CUCS always has great trainings available. CSH, the Harm Reduction Coalition. And I'm glad somebody brought up de-escalation, because that was the other thing I wanted to really, really talk about when we were talking about both the questions of racial justice, undoing white supremacy, really addressing this kind of stuff within our realms here. And it's so important. The first thing is to train our own staff to effectively de-escalate situations, whether the person is psychotic, whether the person is violent. The question is, what do you need right now? What do you need? What do you need right now, right? And
Right.
that brings the person into the present. It gets you engaged with them. And it gives you the ability to give them something.
Mm,
Very good, Nina.
thank you. That I think is an excellent kickoff. We are at 2:30. I just, as the moderator, want to thank Kevin and Nina, my heroes and sheroes in harm reduction and housing first, for what I think has been a very valuable conversation. I have been trying to monitor the chat as well as the questions. We did not get to answer everything, but I think you really represented harm reduction and housing first well, with balance, with grace, with equanimity, with knowledge.
It's not
and
always
perspective.
graceful. It's not always graceful.
And my parting thought is, I do kind of start with that non-judgmental approach. You meet people where they are and try to work to create a path for them that they have full buy-in. And then the rest of it is about, it's the nerdy. it's the art, but the art is there. The science is someplace else, but I do think that's there. And if we can have respect for people and understand some empathy that we also have our own challenges. The coffee cup is right here.
That's right. That's right. And remembering that that's true for ourselves too.
No,
We
exactly.
are also always doing the best we can with what we have.
Can do
Right?
the
So
best
we make mistakes, and helping us to be just sort of more compassionate toward everybody. Thank you, Diane, and thank you, Kevin, and thank you, Shinny. This was so fun and wonderful.
I enjoyed myself.
We have to
And
have
maybe
another
the
one of
next
these.
time I'll learn how to unmute and put on the video, but that's okay. For now,
all right.
Thank you, Shinny, for enabling this conversation. I think we all appreciate it.